It's a very good question. I think last ASH 2018 was very telling for the use of BTK inhibitors. We had two major cooperative group studies, both the Alliance study and the ECOG study, that basically told us that ibrutinib and the BTK family was an appropriate standard of care for basically anyone who has CLL in the frontline setting, and obviously it's well established in the relapse setting before that. So we need to think about it for pretty much all patients, and then we bring in other treatment options for consideration based on the specific patient profile. So for example, if someone has a mutated IGVH, you can consider potentially chemotherapy if a patient still wants a truncated course of treatment. But in general, BTK inhibitors remain the standard for now. Venetoclax in the combination with obinutuzumab has also gained a frontline approval this past year. For those patients, I think most of us who specialize in CLL still think of that regimen mainly for patients who don't have as many high-risk features, because most of our experience for patients with deletion 17p and TP53 is still with a BTK inhibitor in the frontline setting. And then, as you know, as of a few weeks ago, our BTK options include ibrutinib and acalabrutinib, which we don't know if one is better than the other in terms of efficacy. We still don't have a randomized study showing us differences in safety profiles. Our general sort of experience is that while some of the adverse events are similar with acalabrutinib to ibrutinib, some of them, they tend to be a little bit less severe. We're not seeing as much of atrial fibrillation and a little bit less severe bleeding.